For the next session, we move to an interesting debate on rheumatic mitral stenosis. For this, I invite Dr. Sunil Karna, Dr. Kiran Prajapati, Dr. Tushar Bhati as the moderators, Dr. Priyankar Sena, Dr. Neerav Halani, and Dr. Zishan Mansoori as the chairperson. Over to chairpersons.
Good morning, and thank you very much, Dr. Kamal sir. So it is an interesting topic that today we are going to discuss here, and I would like to introduce our first speaker for the bout, Dr. Kamal Sharma, who is MD, DM Cardiology, DNB Cardiology, as well as DNB in Medicine, MNMS, FSCC, FSCI. The degrees don't do justice to him. He is the chairman and convener of the scientific committee of this cardiocon. He is a senior interventional cardiologist with vast experience of coronary angioplasty, stenting, valvuloplasty, pacemakers, and pediatric interventions, a combination of DNB, and should I say, on the verge of IAS as well. He left administration. He had been selected for IAS also. So passionate clinician, I would say. Apart from practicing at Sal Hospital, also in UN Mehta Hospital, and is also been teaching the subject at BJ Medical College, also been teaching the subject of cardiology as well as medicine, has received and worked hard for those 22 gold medals for academic excellence during the medical studies, and the world's first vagal nerve stimulation device in the Anthem study was done by him. He discovered winking coronary sign for VSR on angiography, also known as Kamal Sharma sign of VSR. Principal investigators in the trials like Paradigm HF, Atlas TIMI, TIPS, Seraphine Canvas, more than 200 publications, more than 1,000 citations, more than 10,000 citations, and awarded as excellent teacher by Gujarat University, and the only cardiologist, or I would say one of the rare clinicians or physicians to have cleared the civil services exam in the first attempt. He is also an author of 8 books and a lot many chapters that are cannot be counted on the fingertips. Our next speaker would be Dr. Anil Jain. The legacy of his is unsurmountable. He is the owner, director, and chief at Epic Hospital, Ahmedabad, as a MS in general surgery, DNB in cardiac surgery, more than 28,000 cardiac surgeries in the span of 16 years, with total arterial bypass, beating heart surgery, heart failure surgery, congenital heart surgery, wall repair, wall replacement, surgery for atrial fibrillation, and surgery for aortic dissection. So, an eminent surgeon and a very prominent name when you go in the market. Our third speaker, next slide please, is Dr. Tushar Shah, who's in MS and MCH in CTBS, has been practicing thoracic surgery for last 3 decades. He had won several gold medals and awards during his initial surgical training in Ahmedabad as well as Mumbai, one of the youngest recipient of Hariom Ashram Prerit Alembic Research Award in 1981, before I was born. So interest in lung parenchyma saving surgeries for infective and malignant diseases of lung. He started laser-assisted pulmonary metastatiectomy (LAPM) surgeries using 1318 nanometer diode laser for the first time in Asia in 2011. So I would like to welcome all the speakers, and I guess we would start with the red corner by Dr. Kamal Sharma sir. So over to you, Dr. Kamal Sharma sir.
उसका ENT का जो होता है उसके लिए कुछ टेस्ट होते हैं वो करेंगे.
Sir, you are not audible. Sir, unmute all yourself.
Thank you, Zishan, for kind introduction. Pleasure hosting you all, and again speaking, and with my colleagues and dear friends, Dr. Anil Bhai and Dr. Tushar Bhai. अभी ऐसा हो गया कि अगर अनिल भाई और तुषार भाई नहीं होते कॉन्फ्रेंस में तो it's incomplete. So it's always fun to have you guys for the debate. So I'm going to talk about 33-year-old female, severe rheumatic mitral stenosis, Wilkins of 8, mild MR, severe PH. Best strategy for him is going to be what? That's what I'm going to discuss. So this is the case. Dr. Zishan already mentioned that. A high gradient of severe critical tight stenosis with severe PH. So we have a three-cornered fight. And you need not guess who's not, all the three heroes amongst the three, who's not hiding his face is supposed to be the cardiologist because he doesn't have anything to hide. So he can be open and he can share so you know who is who. Why I would suggest and vouch for BMV, the reason one is just look at the STS scores, how the surgeons interpret their own operative risk. If we were to look at the CMC, OMC, or even MV repairs or MVR, look at the calculations designed by surgeons themselves. Mortality risk are almost 1 to 1.5%. Reoperation rate 5%, morbidity or mortality 11 to 12%, and short stay is in minority of the patient. Long stay hangs to be in 7 to 12% of the patient as calculated by STS version 4. Compare this with BMV. Score less than 8, optimal results would be achieved in more than 90% success, less than 3% complication rate. Compare this with, say, complications here, which is almost 4 times, and 80 to 90% of sustained improvement even during the follow-up of 3 to 7 years. Reason 2 why I vouch for BMV is the guidelines. Look at any guideline, even the appropriate use criteria of 2017, or if you look at the ESC guidelines, all of them, they talk in the ACC guidelines, they talk about in mitral stenosis, it has a class 1A and 1B recommendation, even who are not high risk or who are not candidates for failed previous PBMV. Even then it's 1B. First mention in these guidelines for surgery comes at level 2B. The mitral valve surgery, even when you're planning to do an LA appendage exclusion in severe MS, who have recurrent emboli while receiving anticoagulation also receives 2B. Reason 3 is it's an old data published from GB Pant itself. When they looked at the immediate randomization, and I'm going to talk about Indian patient and hence the Indian data. This is very old patient of Aurora ma'am, which talked about comparing the two, and it found out that the results were as good or even better with BMV with less complication. Internationally, this is one of the paper which actually changed the guidelines. 7-year follow-up, Mohammed bin Farad's paper published in 1998, which looked at 7-year outcome, and there was no early late but mortality or thromboembolism between the 3 groups, but MVA was similar as compared to open surgeries. Residual ASD was in only 2 patients. So my surgeon friends may harp upon creating an ASD. It doesn't last there, which actually is a beneficial thing that you can end up actually going through the PFO in most of them. What about longer duration? 12 years. This is another data from Boletti et al., Long et al. Published, when they looked at 912 patients followed for 12 years. Overall survival rate of 20 years was 75%. This is the longest follow-up data that we can talk about. So surgeons can talk about valves lasting forever, which is actually not the truth, which I will again discuss. But the BMVs do last for quite a long while. And this is our own paper published in Indian Heart Journal, where we looked at even redo cases following previous mitral commissurotomy. So where surgeons have done BMV and OMC, or OMC and CMC, even those patients we did end up doing BMVs with fantastic results. Again, you can see Wilkins score was favorable only in 2/3, 68% of the patient, in 31% of the patient. Most of these patients, despite having a Wilkins score more than 8 after undergoing CMC, OMC, actually ended up getting fantastic results. This is the reason 6, which is a new data, 2021. What about normal sinus rhythm? This patient is in normal sinus rhythm. AF group had less favorable outcome, but this patient is in sinus rhythm. And hence compared the loop, it all published that the patient who do well on BMV for the rhythm versus, say, atrial fibrillation, the normal sinus rhythm in this meta-analysis of 6,000 plus patients actually did much better, especially in terms of the valve area. It doesn't mean otherwise, but you can do BMV and AFib as well. But if you have normal sinus rhythm, it's one of the important reasons why you should go ahead and do a BMV. Of course, the lesser complication, out of 12%, my surgeon friends may hop upon, you create MRs and I have to rush. No, that's not the case. It's very rare that you get an MR in an improper technique or improper valve. The survival rates in those patients actually who have mild to moderate MR it's better than compared to those who don't get an MR, because the MR reflects probably a better opening of the valve. So 8 event-free survival, second PBMV, heart failure requiring admission, was significantly lower in patients who had significant MR post BMV as compared to those did not. This did not mean severe MR, but mild to moderate MRs post BMV are actually good in long-term survival. What about the comparison outcome per se with OMC? Because I have to fight a double corner. You have 2 surgeons punching at my jabs. So I need to be debating that way. So I'm going to take one of them one by one. So PBMV versus OMC, this is a 60 patient data from RISE, where they looked at the Valvular valve area going up from 0.9 to 2.1 as compared to only 2. So which is actually, I'm not saying superior, but surely non-inferior. Actually, probably surgery, people are harping on being non-inferior here. After 3 years, patients with percutaneous had a higher average valve area and a greater likelihood of NYHA functional class as compared to patients who underwent open surgery. Now, there is a problem why the surgeons were wearing a mask, why Batman and Spider-Man had to wear a mask, because you end up replacing one disease with other. This is not what I said. This is what Denton Cooley said, that leaving a prosthetic valve to a patient is replacing one disease with another. And what is that disease? It's a disease of prosthetic valve. What is that? The thrombosis or the bleeding. What is the thrombotic risk in life-threatening complication? 1.8 to 5.7% per year per patient. So that is per patient year, you have very high risk of a patient coming up with a choked valve. And then you will have to actually end up giving a thrombolytic therapy, or maybe you'll have to reopen by doing another surgery. What about bleeding? If the patient is on VKA, 69% of VKA versus 31% on, even if they end up with prosthetic tissue valves. Tissue valve patients, even on aspirin, end up bleeding. 3-month post-operatively, cumulative incidence of the combined endpoint was 9.2% VK, 11% aspirin. No difference observed in thromboembolic. So VK aspirin should have similar event rate of 10% during 3 years, 3 months after MBR in patients without prior AFib. Other my surgeon friends may harp upon is cost. Of course, balloon mitrals, even when you use new balloons, is going to be cheaper than having a replacement or open surgery. And on top of that, mere paas maa hai. So that's the MA card. That's the insurance that the government provides. You inflate the balloon and the balloon valve is actually better because you go fluoroscopically rather than a blind procedure like closed mitral commissurotomy. What about duration of hospitalization? 1 to 2 days. OMC, CMC, MBR, even if you're a fantastic mini thoracotomy surgeon, 5 days. This is the pain, scar, anesthesia. That's all you end up. We just go from the groin. And remember, we are not even puncturing the artery for the sake of procedure. It's just the vein. The anesthesia, of course, we just do under local anesthesia as compared to endotracheal intubation. And this is how we actually have access not only to what we are doing, but also having a fluoroscopic look of inflating the balloon and controlling it and looking out for the procedure perioperatively by echocardiography. So why replace one disease with the another potential one? So the good news is that we have got very few customer complaints, because the bad news is that most of the customers end up getting BMV. So you will have probably in the time of mitral stenosis may not have more patient complaining about valve thrombosis if they end up with getting more BMVs. And with the Joker's quote, with the 3 heroes, I think the villain also has to come in. So whoever fights monster should see to it that in the process, he does not become a monster. When you end up probably treating a disease, you should not replace that disease with another disease, which is a valve. Thank you very much. Over to Chair. Thank you for patient hearing.
Thank you very much, Dr. Kamal Sharma, sir. And for the blue corner, I would like to invite Dr. Anil Jain, sir, for his presentation. Over to you, Dr. Anil Jain, sir.
यहाँ से खोलना पड़ेगा ना रूम वहाँ पर क्या बोलेगा करना चालू Just 1 second. Can you see my screen? Hello, can you see my screen?
Yes, it's visible, sir.
The presentation is visible?
Yes, yes, absolutely. Go ahead.
With all the bashing that Dr. Kamal Sharma gave, I think I needed a sip of water. So let's go ahead and see. You know, it's very easy for a cardiologist to say that surgeon can do nothing and they are like God. There was a time when cardiac surgeons were treated like God. And now today's cardiologists have come up and started saying, we are God, we can do anything you want. And but they are the judge and the jury themselves. And hence they think that whatever they do is the best. Well, you know, actually, Kamal has forgotten to see what his patient is suffering from. The patient has mmHg class 3. She has got intermittent palpitation, which may be a symbol of which may be underlying atrial fibrillation. And she has got severe pulmonary hypertension. And she has got a Wilkins score 8, but there is no clot in LA. So let's see what happens. What is the aim of treating any patient with valvular heart disease? Our aim is to neutralize the disease, and survival and quality of life should be same as the age-matched population. I'm not talking of 5 years, 6 years, 7 years. Patient should live as long as any other person lives of that age, and we want to neutralize the disease. How can you neutralize the valvular heart disease? If you get the patient into a normal atrial and ventricular function, there is no rhythm disturbance, and perfectly normal long-term function is what we are aiming at. You're not looking at, she's 30 years old, 33 years old. She's got to live for 80 years. You can't talk of 6, 7 years of stuff and say that's okay. How can we do this? We should get her valve area more than 2 centimeter squares, and we should try to get her back into a permanent sinus rhythm where there is no episode of palpitation at all, and resolve her symptoms. Mitral valve is not a simple thing. It's got chordae, it's got papillary muscle, there are 2 leaflets. I think I would like to invite Kamal one day to the theater and show him how complicated this valve is, not something just to be blown up with a balloon where you don't know what's being blown up. So if I was a surgeon, what would I do for this patient? I would do a commissured to commissured complete valvotomy. We would ligate the LA appendage. We will go down to see the subvalve, the chordae, split the muscle, split the chordae, remove whatever pathology is there, decalcify the leaflet, do a biatrial maze. And if this patient has got tricuspid regurgitation more than moderate, or if her tricuspid annulus is more than 40, I would also like to repair that. Mind you, this patient got severe pulmonary hypertension and she can have moderate TR. And by all the guidelines, if there is more than moderate TR, when you are addressing mitral stenosis, atrial tricuspid valve repair is must. I have seen more suffering and more misery with tricuspid valve repair than I have seen with primary valvular heart disease. So surgical exposure is wonderful. There's a lot we do on the table. We split the commissure, split the submitral apparatus, split the papillary muscle, split the chordae. We make it absolutely normal, and we put a ring. And what do we get at the end of the day? We get a patient who has a valve that has no mitral regurgitation or maximum mild possible regurgitation. We would aim for an area of more than 2 centimeters and a normal sinus rhythm with an LA appendage that's ligated. So basically, all the pathology has been corrected. So what have the results been? You know, what is the actual survival of a good open mitral repair? 94.6% at 14 years. Sorry, it's not 4 years. And an 83% at 14 years free from reoperation. And there is this particular study by Antunes, who was one of the leaders in valve repair and leaders who promoted valvular heart surgery. He says that there are not one, but so many patients who have, you know, more than 20 years of survival without any reoperation, without a problem. I'm sure all of you have seen a patient of CMC which was done maybe 20, 30 years ago, and still the patient has a valve area of more than 1.7 or 2 centimeters. In this study, he said that most of the patients who had preoperative valve area of 0.99, post-op had areas of 2.88 centimeters square or more, and 37% had more than 3 centimeter valve area. Means that's the normal mitral valve. That's what the surgeons aim for. We don't aim for slipshod or half-hearted jobs where we just blow up a little bit of commissure and say, oh, the patient is okay. We look at 98% freedom from reoperation, 98% freedom from mortality. We look at 98% freedom from complications. This is what we aim at. This is what valve areas we look at. More than 2.5, 3 centimeters means the valves have to be wonderful. They have to look like brand new valves when you go and repair it. It's not just opening a little bit of commissure that makes a person okay. So let's get that one clear, that surgeons do a very nice job, a complete job. And what if I'm on the table and the valve is not okay? I can just go in and replace it. Not like, you know, you've got a leaking blood into the pericardium where something is punctured, or a severe MR and the patient suffers all night, and in the morning you come and tell me, oh, that patient has got severe MR. Can you do him now? And by the time that patient is dead, it's not like that. We can just go and straight away change the mitral valve and put a new valve. And prosthetic valves, they are wonderful right now. You have an actuarial survival of more than 75% at 15 years. And let me tell you, new valves are on the block. There is a new TRIA valve that's coming, which will not need anticoagulation, and it will last for the patient's life. It will be a game changer as it comes by. So surgeons have not said the last word yet. Let me tell you that. There's a lot that's happening, and there are not one but ample number of trials that show 15 and 20-year data of mitral valve replacement or aortic valve replacement where prosthetic valve patients have done very well. And I'm sure, Kamal, in your OPD, you must be seeing some patients that we operated in 95, 96, when I was at UN Mehta or Institute of Cardiology, and they're still coming back to you for follow-up. So prosthetic valves do well. Not all of them die with thrombosis or problems. That people die. Some patients die. And most of the data everywhere says that definitely repair is better than replacement, but replacement itself is not bad. So what should we do? Repair or blow up the valve? Surgery can neutralize the disease, but can BMV give a better result? Let's see what there is to be said. Now, look at this. You have said that the Wilkinson score is 8. What does Wilkinson 8 mean? Let me tell you that Wilkinson is a very vague scoring. Wilkinson score is a very vague thing. It just talks about mobility, thickening, some calcification, something like that. There are 4 criteria, and you just make 8 out of this. But does it look at commissural calcification? No, it does not look at commissural calcification. Does it look, you know, that is the most singularly important thing in a valve. Does it have commissural calcification or not? And there is nothing about that in Wilkins score about commissural calcification. So what are the limitations of Wilkins score? All the cardiologists jump around. Oh, Wilkins score 8, let's do it. It has many limitations. Number 1, it doesn't look at commissural calcification. It's very observer variable. Observer may think this valve leaflet is good. The other one may think it's bad. And I've always seen, even if I show them a report of 8, the cardiologist will say, I'll have a look. Then he goes and have a look. And then he says, no, this one is calcified. This one, the commissures are not good. Something is wrong. So let me tell you, we are going on a very, very, you know, a score system that is not perfect. It has nothing about it. 8 means nothing according to me. So if you ask me, and again, Wilkins score does not have anything about contraindication. Can you believe a score that there is no contraindication? Anybody, according to this 16 scoring, but the risk is low or the risk is high, go ahead and do a BMV. You don't know what the leaflet is like. You don't know what the commissures are like. Just a little bit leaflet thickness, little bit subvalve fibrosis, and just go and do a BMV. Wilkinson is 8, I am happy. Wilkinson is 9, I am happy. 2 observers, if you send for an echo, both will give you different results on Wilkinson. So that does not mean anything, let me tell you. More than that, does Wilkinson identify the high-risk subsets? No. You just look at Wilkinson, go and do a BMV. No, it's not like that. ACC, AHA, and ESC all have defined certain high-risk criteria. They say whether the anatomy is good or bad, there are certain contraindications to BMV. And in that, they have mentioned atrial fibrillation and severe pulmonary hypertension. This patient has severe pulmonary hypertension, intermittent palpitation, which definitely stands for atrial fibrillation in the developing, means her left atrial appendage is already hypertrophied and she can get into trouble. Now, what is a successful BMV? Have you ever heard what is a successful BMV? A successful BMV is where the valve area becomes double or there is a 50% improved from the previous valve area. Do you know when a cardiologist comes and said, valve fully gayu chhe, means from 0.8 he has made it 1.6. And I would like to ask the audience, how many have you seen valve areas post BMV that cross 2 centimeters? In my life, till now, I have not seen one valve that has come with an area of more than 2 centimeters. 1.5 is excellent result. They will write excellent. Mild to moderate MR, BMV area 1.5, this is very good. But does everybody in the audience think a 1.5 is good? And suppose if the area is 0.6, and this is from their journal I picked up, double the valve area or 50% gain from pre-BMV area. Now, what is 50% gain? If it is 0.8 and you make it 1.2, it is still mitral stenosis. So this is a very subjective thing. Send me these echoes. I'll have a look and tell you what the real valve area is. So it's that a good BMV, they're scared of MR. So they'll inflate the valve a little, come in, come out, both MR. That's how it goes. So that's not the way you treat a patient. And this is totally subjective. Let me point out this paper to Dr. Kamal Sharma. I think you should start looking at commissural area ratio and leaflet displacement. These are better guidance than Wilkins score for a BMV, because this looks at commissural calcification, which is more important. Also, you should have a better look at the submitral valve apparatus, that you carefully, you may open the valve up there, but if the submitral is bad, the patient still does not make it. That's very important. People say commissurotomy outdated. Look, patients have data of 20 years, 30 years, 40 years. This data is up to 30 years, where there is 45.9% survival at 30 years, which is excellent. This particular paper from Antune says OMC remains the best alternative for treatment of all cases of mitral stenosis, independent of degree of pliability. In our experience, the median long-term results are significantly better than those usually reported in PBMC series. And these are all big pioneers. This is from Shiv Kumar Chaudhary, Delhi, where they have seen an average mean area of 2.6 centimeters plus minus 0.6 centimeters, and their long-term follow-up shows excellent survival and good results. You know, many times we wonder, why should BMV not be as good as OMC? I'm sure none of you have gone and read your books of rheumatic heart disease and its pathology after finishing MBBS. Rheumatic heart disease is such that if there is turbulence, if the flow is not good, then recalcification can happen. The main reason, Spencer et al. Have reported, the main reason for better result is reduction in turbulent blood flow created by a widely patent and competent mitral valve, diminishes progressive valve fibrosis, and generally obviates the need for future valve replacement. So surgeons can obviate the need for future valve replacement because we do a complete job, not an incomplete job like our cardiologist does. And you have open mitral data of 18 years, 20 years, for years and years we have data that is excellent. See, they will show
up a little bit, sir.
2 minutes, just 2 minutes. BMV, some data is presented to us, but go and look in general in the data. What is it like? BMV event from survival 69% and freedom from stenosis 71%. Actual survival 56% at 10 years. This is the type of data I came across when I went on the internet. So what do you want? You want a patient who lives happily, who's got the disease neutralized, who does not suffer from atrial fibrillation, pulmonary hypertension, and multitude of complications. I've seen patients who had a BMV. After 5 years, they say, balloon, now we go ahead and do a mitral valve replacement. And when that patient comes to us, that patient has severe pulmonary hypertension, atrial fibrillation, tricuspid regurgitation, and a multitude of complications. And then the patient doesn't do well, and they say the surgeons messed up the case. So I think a stitch in time saves 9. When the patient comes, do a good job, open the valve completely, make the patient normal, and let her live. Don't do something like a PT-BMC that is just for show. You've just blown up the valve a little, don't know what really happened to the complete pathology in the valve, and let the patient suffer for 5-6 years, then say, this worked well for 4-5 years, that's enough. Now we can just go for an MVR. No. When you do a procedure, for 30 years, the patient should do well. Thank you very much, Dr. Kamal Sharma. I don't want to say more than this. I'm not here to criticize the procedure. I know it's a good procedure, but I think you need to go back to the drawing board and look up to everything and try to do something better than. And so don't think we are villains. We are very good people and we give a good long-term survival, and patients will live. We want them to live. Thank you so much.
Thank you, Dr. Anil Jain. We have no doubt on your competency as a surgeon. What happens is that whenever we refer a patient for an MV repair, surgeons only advise that MVR is indicated, and what happens is that they end up putting a prosthesis in the patient's heart. So that's why we are afraid to refer the patients to you for repair.
You have to find the right
Exact
person
reason
for the
why I
right
kept the
job.
debate.
You can't send it for any person, right person for the right job. We have more than 1,200.
But sir, when the patient holds up a trump card of a mmHg, then you are not accessible.
Well, then your patient has to pay something for a good quality and long-term life. Ma is not the excuse.
Let's hear Dr. Tushar Bhai,
platform.
and then we can have discussion.
This is a scientific platform. Ma is not important. What is good for the patient is important on a scientific platform.
Tushar Bhai is champion of my Yojana.
So over to you, Dr. Tushar, sir.
Hello.
Yeah, please share your screen, Tushar Bhai.
Full screen. Yeah, I'm sorry.
By the time he shares, I think we can, I can rebut at least one thing what Anil Bhai said, 50% and you get away. It's not like that. You say 35% mark aate to pass ho jata, aisa to hota hoga, somebody can argue, but that doesn't mean there are not people who not get 99% marks in the exam. 50% is defined as passing of the BMV. If you don't do 50% of the area, your procedure is unsuccessful. And that's what I showed, that even by that marking, 90% of the people are passing. That means 35% mark lake pass hona hai, to class mein 90% people are passing. So 90% of BMVs get area more than double. That is what it meant. Don't try to twist that we always end up getting only half double the area. Most of the times, as I showed you, you can get area as high as 2.2, 2.1, and I showed you papers on that. We can come to that. I think Tushar is ready with
I don't want to argue on that point because I've seen all the results.
Yes, I'm ready.
Yeah.
There are two things which, before I start my presentation, to point out. One is Kamal has given a topic which is overlapping between Anil and me. So there is bound to be some discussion which will be common to both. And secondly, I want to remind all of you that everything has been said before, but since nobody was listening, it has to be repeated again. This is what Andre Gede said. OMV and CMV are very much alive, extremely relevant and modern. To consider them old-fashioned is wrongly banishing the huge patient population of patients of mitral stenosis either to incomplete treatment, and that is BMV, or unnecessary mitral valve replacement. There is a great place of OMV and CMV in this scenario. Of course, I do admit BMV is a procedure of choice. Isolated, uncomplicated mitral stenosis with very favorable morphology, like nicely pliant, non-calcific valve, minimal subvalvular crowding, consistent sinus rhythm, not intermittent, and no left atrial thrombus. Go ahead, Kamal, do a BMV. But remember what I'm saying. The profile that you have given me is incomplete. There is no mention of rhythm, no mention about LA clots, and there is no mention of tricuspid valve disease. This is exactly what cardiologists do. They ignore rhythm, LA clots, tricuspid valve, just see Wilkins and blast. They are likely, these patients are likely to be having severe pulmonary hypertension, and therefore they have atrial fibrillation, clots, and tricuspid valve disease, which has not been mentioned in the profile that you have given me. Anil has told you that mitral valve is not just cusp, it is cusp, chordae, papillary muscles, and rheumatic pathology affects everything. Unfortunately, BMV just separates the leaflets. Chordae and papillary muscles are not touched, and they form a formidable part of pathology. This slide shows the progression of a normal valve to calcific valve, stenosis valve, the chordae, normal chordae, and then shortening of chordae, and then crowding and papillary muscles getting attached to the cusp. Tell me how balloon can do anything to this congested chordae and papillary muscles attached to the mitral cusp. It has to be opened up mechanically. At open mitral valvotomy, we use cardiopulmonary bypass, left atrium is open, mitral valve pathology is studied systematically, valve is open at cuspal, chordal, and papillary muscles. There is, if mild to moderate cuspal calcification, cusp can be shaved off. thrombus can be removed. Left atrium can be plicated in presence of giant atrium, which we all know. Biatrial maze can be done. Left atrial appendage can be excluded, and tricuspid valve is repaired if there is moderate to severe regurgitation. So you treat the patient completely. Do not treat just the cusp, which BMV does. This is the technique of mitral valvotomy. These are operative pictures. Anterolateral fused commissures, posterolateral fused commissures are separated. The subvalvular structures are cut, and division of the papillary muscles with port scissors is done so that mitral valve is competent and yet fully open. What does BMV do? It simply spreads the fused commissures. It does not adequately treat subvalvular crowding, which may form an important part of pathology, and it ignores clots, atrial fibrillation, and tricuspid regurgitation. What are the indications of open mitral valvotomy? Absolute indication: presence of thrombus, atrial fibrillation, subvalvular clouding, calcification, failed BMV, restenosis after BMV, restenosis after CMV, significant aortic stenosis, and mitral stenosis, which can be opened up very easily, moderate to severe tricuspid regurgitation, and large atrium, mild mitral regurgitation. These are the times where open mitral valvotomy will be ideal. Dr. Sampath Kumar's paper has already been referred by Anil. This is a landmark paper which established open mitral valvotomy as a technique which is not relegated to the past. What are the advantages? I mentioned again, but it is important to reiterate. Direct inspection of the valve pathology. There is no procedure, neither BMV nor closed mitral. You see the valve completely and do whatever is necessary. Kamal will just see an image, its image, and then intensification of imagination. But not real picture is seen by any cardiologist. There is careful debridement of calcium deposits. Subvalvular structures are separated, and rest of the things I have already mentioned. If valve is bad, in contrast to what was found on echo, valve can be replaced. 30% of patients with isolated mitral stenosis have atrial fibrillation. Stroke and peripheral embolizations are ever-present threats. Atrial fibrillation reduces cardiac output. Tachycardiomyopathy is the end-stage disease, and there is chronic fatigue and cardiac failure. This is the place where the appendage gets clotted, and then the clot spreads into the left atrial body. Incidence of atrial thrombus: 25% of patients with mitral stenosis have atrial thrombus. And routine transesophageal echocardiography will detect many more. It is a major cause of morbidity and mitral stenosis. What can you do on BMV with these clots? I am told that you give anticoagulation for 3 weeks and then you can do BMV. Now here is what Cardiology Journal of Heart Valve Disease says. Effective resolution and organization of left atrial thrombi needs optimal 6 months. In order to opt for BMV, patients are asked to wait and suffer symptoms and take long-term anticoagulation with its possible complications. Some patients may embolize in spite of anticoagulation during this waiting time. Some patients go into severe symptoms, low output state, needing ICU care while waiting for BMV. While here we have OMV, which is next day procedure, quick, definitive, and removes all clots completely. So don't ask your patients with atrial fibrillation to wait for a long time and then persist with BMV. Offer them quick and effective solution right away. This is how we convert atrial fibrillation into sinus rhythm. All the lesions, left atrial lesions are shown, and left atrial appendage is also excluded. You can see in the figure. And this is right atrial maze. Complete maze gives you 70 to 80% of the patients from atrial fibrillation into sinus rhythm. Nothing can be done like this in a BMV. Left atrial appendage is excluded. Sometimes in exclusion of left atrial appendage is a hot topic in cardiology. So many devices and procedures have been described, but they ignore the same fact while doing BMV. Why not exclude left atrial appendage? We can do it at the same time when we are doing open mitral valvotomy. There is a comparison between BMV and OMV. OMV gives better long-term hemodynamics and lower rate of restenosis. BMV is a half. Yes, I agree. BMV is a procedure of choice only in selected patients due to its less invasive nature. This again was quoted by Anil, immediate and long-term results of balloon and surgical closed mitral valvotomy, randomized comparative trial. Remember this, 40% of all patients with RHD have MS and MR together. Most of them have symptomatic severe mitral stenosis, but significant mitral regurgitation. For most patients with pre-existing moderate mitral regurgitation, BMV is out of question. It's contraindication. So how many few patients left? 40% patients with mitral regurgitation are out. 25% of atrial fibrillation are out from BMV. 25% of patients with clots on transthoracic echo, they're out for BMV. So just imagine how much is left for BMV. Mitral commissurotomy, a technique outdated. Here is a paper which has studied for over 35 years. This meta-analysis says it's a systematic study of effectiveness of BMV versus closed and open surgical mitral valvotomy. It's a very, very painstaking study over 1974 to 2010. All clinical control trials were compared. Abstracts for major cardiology and cardiac surgery meetings were studied. References also were studied and even corresponded with authors of all relevant research. Very landmark article. And what does it say? Sorry. No difference in mortality. Yes, we admit in BMV there is mortality of 4.13%. In surgery that is 3.24. Fine, we accept. Survival after BMV was significantly lower compared with OMV on long-term risk. Surgery has the inherent superiority over BMV in providing the potential for additional surgical techniques which may improve late survival and restenosis rate. Inherent superiority over BMV. 30 to 50, this is very, very important, Kamal. Listen to us. 30 to 50% of BMV patients develop mitral regurgitation and 4% need immediate surgery. But let's not forget, mitral regurgitation begets mitral regurgitation. If you leave mild mitral regurgitation, oh, that's mild mitral regurgitation. After 3 or 4 or 5 years, it will be severe mitral regurgitation. Did not show any significant differences in terms of operative and late mortality and complication. Incidence of late new onset MR and late re-intervention were significantly higher in patients with balloon. Surgery remains the treatment of choice for rheumatic mitral stenosis. Here is another paper. Study of 314 patients. 32% of the patients had moderate to severe tricuspid regurgitation. And the third point is absolutely important. I have highlighted. Tricuspid regurgitation did not improve in 88% of patients studied. Don't say that this is functional tricuspid regurgitation. We have opened the valve with balloon, tricuspid regurgitation will resolve. No, in 88% it doesn't resolve. TR, functional or organic, must be treated to avoid long-term disease of severe TR and dysfunction of the right ventricle. So another group, 32% are out from BMV. It just takes 10 to 15 minutes to repair tricuspid valve and give patient a symptom-free life for long years. Leaving moderate to severe TR untreated at the first instance when you do BMV is a crime. However tempting, an easy BMV appears based on, into inverted commas, Wilkinson score. Reduced functional capacity, heart failure, massive pedal edema, ascites, hepatic dysfunction, and metabolic consequences are too well known because of severe TR. Anil definitely pointed out to this. Long-term effects of progressive TR are grave, leave the patient miserable, and attempt to correct surgically will have mortality more than 50%. This is how the tricuspid valve is repaired in just 10-15 minutes. A ring is established and that's it. And a long, good life is given to the patient.
Requesting you to quickly summarize as the time is running over.
Incidence, prognosis, implications, mechanism, and management. This again is a very, very important article in Cardiology Journal. It says 1/3 of the patients with mitral stenosis have at least moderate tricuspid regurgitation, and all moderate tricuspid regurgitations need treatment. BMV turns a blind eye to significant TR. They just don't look at it. This is what it happens. You leave TR, moderate TR, and over a period of 3 or 4 years, it becomes severe and patient's survival decreases to 50%. And if it is severe, the survival decreases to 40%. So the myth of functional tricuspid regurgitation. Let us all together admit that there is nothing like functional tricuspid regurgitation if the tricuspid annulus is more than 35 or 40 millimeter. And every day, day in and day out with BMV, 50% of the patients will have this TR, which is tricuspid annulus, which will be 35-40 millimeter, and they all will come back after 5 years with gross TR and ascites. Results of repeat surgery are extremely bad, and prophylactic tricuspid regurgitation repair is also now indicated. If the patient has dilated tricuspid annulus, there is no significant TR, but dilated annulus needs repair, cannot be done in BMV. Giant left atrium is common in our country, though literature says it is just 0.3%. And in our country, it is much more than that. 8 centimeter or more anteroposterior diameter of left atrium measured in this axis. And consequences, what are the consequences of giant left atrium? Decreased cardiac output in spite of correcting mitral stenosis.
So we can have discussion, Tushar bhai, now.
Yes, just a second.
Yeah,
Let me complete. In defense of closed mitral valvotomy, this is the procedure, and these are the articles proving, recent articles proving the effectiveness of closed mitral valvotomy. CMV represents a satisfactory technique in terms of lower cost, high efficiency, simplicity, and reproducibility. When compared with balloon, CMV offers a satisfactory technique. It can be done in pregnancy, and we have done even at bedside. Which procedure can be done at bedside? OMV and CMV, OMV is far better, but like BMV, CMV also has limitations in long-term results. BMV and CMV, we conclude with the immediate and long-term results of BMV and CMV are same, but CMV results in better long-term survival and fewer valve-related complications as compared to balloon mitral valvotomy. And BMV and OMV are more or less same, but late results are better with OMV. Do not, this is my message to all of cardiologists, do not just look at the balloonable mitral stenosis as dictated by Wilkins score. Look at the patient's presentation. Do not do half-hearted treatment at the first instance. This is her only chance of a good life. Complete treatment at one go gives the best short and long-term results. Untreated pathology spoils the patient's medical history. BMV, but BMV has an excellent role in selected patients. Rheumatic mitral valve disease is a progressive disease. These are the pictures of 2 grandmothers. The first on left side underwent open mitral valvotomy in 1984. She was the first open heart operation of Gujarat. And in 1904, she underwent mitral valve replacement. She is doing very well. There is another grandmother who underwent closed mitral valvotomy by us 37 years ago, 1985. And everything is good with them. There are no events needing hospitalization. Friends, let me assure you that if you offer these procedures in selected patients, BMV will be out of consideration in more than 30 to 40% of the patients. Thank you very much, Kamal, and all friends, Jignesh, Ladda, Kalpesh, and Prashant, for giving me an opportunity to talk something which I used to talk in 1985. Thank you so much.
So I would like to ask our moderators to give a quick bite of what do they think of these presentations, and then we can move on to the question and answer. So there are some questions in the chat box as well. So, Dr. Sunil, Dr. Kiran, please give us your point of views.
Yeah, good noon. So basically, we are running out of time, but still I have some question and comments to make here. Like one thing, MR begets MR, that is not for rheumatic diseases. MR begets MR is for dilated cardiomyopathy, where if there is MR, then it causes heart enlargement and again secondary MR. For rheumatic, what we see is even if people develop MR during the procedure, unless it is not tolerated or there is no tear. If it is due to tear, then yes, it is not tolerated. Otherwise, many of these mild to moderate is well tolerated. Even if severe, if the left atrium is very large, they do tolerate, and over a period of time, it actually disappears. Like the rheumatic pathology is like that. Ultimately, there is a commissural fusion, and that is bound to happen after a BME. So there is commissural separation thereafter. Over a period of time, we have few patients who develop severe MR during procedure, didn't require surgery immediately because the LA was large and somehow they got this blood was adjusted, and over a period of 6 months, it became mild to moderate. So this MR begets MR is for DCMP. That will not be valid for this rheumatic diseases. Second is for AF, as Tushar sir said, AF is out. No, AF is not out. We do not consider if the patient is AF. It's not like we do not consider BMB. Many AF patients, BMB can be considered. It is not a contraindication anyway. Third is, it is not a contraindication anyway.
Shall I respond?
Yes, sir.
Come on.
Let them finish all the questions, then we'll respond together, Tushar. Let them come up with
I think let's have all questions in a go, and then we all get 2 minutes each to rebut. I think that's how we should do.
Then third is about, like, none of us are here cosmetologists. So how it appears on table after a MVR, like everything is open, now this is open, that doesn't matter if the outcomes are not different. That is what it is. None of us are cosmetologists. So it appears too good on table with MVR and may not be good because we are only opening the commissures. That doesn't matter if the long-term results are okay. So this is third thing. And another is about the males. So particularly these patients are young patients. Whenever these rheumatic patients need valve intervention. Anyway, even after MAGE, if the patient is in AF, you have to give anticoagulation with all its tools. So that doesn't make it that the anticoagulation is not required even if you are doing a repair. So for AF, a patient is in AF, if you are doing MAGE during repair, then also patient need to be on anticoagulation. And the embolism risk, because the embolism risk remains even after MAGE procedure and conversion to sinus rhythm. And third, another thing about mortality. So most of the papers quoted here are from centers, some from India, many from abroad. But the real life data, if you see old data, I think some 20 years old data from AIMS Delhi by Dr. Sampath Kumar. So what he has shown is the patients, many of patients at AIMS Delhi come from Bihar, UP and so many remote places, and the actual mortality at 1 year was 30%. That is too high after valve replacement. So valve repair can be an option, but many places valve repair is not being done. Once they open it, it becomes like the valve is too bad and it is replaced. So it doesn't, in a Indian scenario where the anticoagulation, the compliance to treatment is not very good, and the mortality, we cannot accept a mortality of 30% in the real life scenario at 1 year.
Yeah, Dr. Priyankar, please go ahead. Dr. Priyankar Sinha is there. Yeah, quick comments. Yeah. Yeah, Dr. Priyankar Sinha, he's a cardiothoracic surgeon doing a lot of valve repairs. Please go ahead.
I'm sorry, I just wanted to make a few points that there has been a lovely discussion. I have been traveling some missing bits and pieces of it. But the thing is, what we wanted to highlight is the anatomy. With the anatomy of the mitral valve, we need to understand and analyze the anatomy very well. Once we understand the anatomy and the morphology of the diseased valve, it becomes very easy to choose between whether we want to do a BMP or a CMC or a mitral repair or a OMC. They're all complementary procedures complementing each other at various times. They are, I would beg to say that they are all brothers and sisters. Everything has a place, and I think that valve morphology would define what is to be done. Thank you so much.
Yes, Dr. Kiran. Good morning, Kamal sir, Anil sir, Tushar sir, and other panelists. Just I want to comment that as we have discussed that, I think the patient's condition of the valve and the timing more for subjecting patient for BMV or OMC or CMC or MBR. One thing I want to ask to our surgeon panel that at which point you consider that this OMC is successful and then long-term outcome is good. So patient may not need surgery maybe near 10 years or something 10 to 15 years at least. So just I want to know that. So because we have to tell that okay, this is no, you are now OMC is done and then mostly you will not require MVR maybe in coming 10 to 15 years. So just I want to know the end point after surgery when you can say that now this is successful OMC and then the patient is now having a good long-term outcome.
Good question. I think I'll just add one point. Anil bhai said आपका double area हो गया, आपको पता चल गया. आप CMC करते हो तो उसमें तो पता भी नहीं चलता है double भी हुआ कि नहीं हुआ. Your counter on that.
Kamal,
now let's
Anil, let me reply to Kamal. Close mitral.
How on table do you know that the OMC is successful when you've done a tooth dilator from the closed apex?
There are two things. One is finger. Finger palpates the stenosis and finger palpates how much valve is still unopened. One.
And we see on echo.
Secondly, TE during the procedure and after the procedure, and it is the ultimate cardiologist on table tells you that you have done a good job. So it is a very controlled, nicely controlled with finger itself.
Yes, sir. And so we also see on echo, if the area is not opened completely, we again do another inflation by going up by Hung's formula. So but that's the answer to Anil bhai is 50%.
Nothing better than digital palpation.
Yeah, not gynecologists.
Yeah, I think it's gynec and surgeons, prostate, unless palpated PR doesn't work. Otherwise, it's not a prostate.
I just want to reply to Dr. Kiran. See, Kiran, usually if we see a valve area, after we've done an OMC, we do a complete job like ring and OMC and subvalve division and everything. We do a repeat echo, and if the valve area is more than 2 centimeters, there is no gradient, there is no, no mitral regurgitation is considered as a successful repair. And that is the benchmark. And we usually get that if we've done a good job, that's no problem. And with that sort of a repair, 15, 20, 30 years is not a problem if the patient is put on penicillin prophylaxis.
For the LA appendage closure, just my counter was that a lot of trials have shown that it is non-inferior to anticoagulation, including our Watchman devices. You know, we have got fantastic devices, but still you don't have to choose them ahead of anticoagulation. So just for the sake of ligating an appendage, at least you should not be going an open heart thoracotomy for a surgery.
Kamal, I can tell you that if you are going to,
are you going to stop anticoagulation after ligating the appendage if the patient is AF? Yes or no?
I have a question for you. Why do you not do a BMV to a person who has got a clot in LA appendage?
We do, and we have published our case report series of Manjunath grade. We have published in those in which Manjunath grade 1, 1A, B, and 2A, we have done appendage clots. Also, this case, see, if there is a large LA clot, there is no debate. Point is, when a patient comes with mitral valve disease and he is normal sinus rhythm, does not have LA clot, should he not be undergoing BMV was the question.
No, your patient is intermittent fibrillation. The patient has got severe pulmonary.
No, that's the assumption. Palpitation can be sinus tachycardia. Palpitation can be simply because of the exertion dyspnea. It's nowhere mentioned AF. For that, you may do an halter and document an AF. Even then, I don't mind if the echo is okay.
Show me
go ahead and do it. Even if it's an AFib and if there is no clot, I'll go ahead and do a balloon fight.
You should do a halter before that. Give me the halter report. Give me the tricuspid valve report. You will not put that there.
And for the tricuspid, the BTV, balloon tricuspid valvoplasty, is even easier, safer method. You actually never have a TV repair required for a tear in the tricuspid. Never reported.
Tricuspid
Never reported. And for TR, in TR, if it's organic TR, you always have associated TS. The TR regresses when the pH regresses, which regresses in 90% of the patients when you relieve mitral obstruction.
This is your belief.
It doesn't regress. I showed you a
It
slide.
doesn't regress.
I showed you a reference from American Journal of Cardiology, which says 88% of the TR does not regress if the tricuspid annulus is more than 3.5.
Yes, so that's not the case here. That is organic. When you have 3.5 annulus, it's organic.
No, Dreyfus, you must
my
see
dear friend, there is nothing like
papers.
functional or organic. If it is dilated tricuspid annulus, it is dilated
compulsory.
Annulus.
Exactly, if it is dilated, which is not here.
No, TR.
Moderate and
not
more
here.
than moderate TR with pulmonary hypertension, if present at the time of surgery, should be corrected. And let me tell you, I've seen horrible results. If
you have
even
to go by
MDR,
the tricuspid annulus rather than just looking at the pressures and the jet area when you're looking to define organic.
You have to
If
give
the annulus is not dilated, even if you have severe TR, it is functional.
No, it doesn't work. That
Functional
TR must be
tricuspid
corrected.
regurgitation is a myth for most of the patients.
Yes.
And coming back to Dr. Sunil's question, MR begets MR. This is a very well documented fact in all textbooks of cardiac surgery. You take Kirkland, you take Spencer, you take Wilkins, everybody says rheumatic mitral regurgitation by and large is a progressive reason. How? Yes, I agree. Initially, after BM, yes, you are right. Initially, after BMV, if there is little increase in MR with fibrosis, it might decrease. But after 3 to 4 months, if there is MR, it is bound to progress to severe mitral regurgitation needing intervention, repair, or replacement. Secondly, Dr. Sunil raised a question of AF is not a contraindication for BMV. Yes, it is not. But can you convert it to sinus rhythm? Conversion of sinus, listen, let me complete. Conversion to sinus rhythm obviates so many complications of atrial fibrillation, which are well known to you, more known to you than to us. Sinus rhythm, there is worst rhythm in the body is atrial fibrillation. Yes. And conversion to sinus rhythm gives an excellent life, which BMV just cannot, whether you give anticoagulation or not. If the LS size remains large, we would still give anticoagulation in a very low dose. But most of these patients, more than 70% of the patients have 5 years sinus rhythm. What more do you want? Third question was
atrial fibrillation, tricuspid regurgitation worsens faster.
Yes.
If there is AF, the TR worsens faster than the patient in sinus rhythm. If you've not corrected the TR and there is AF.
All of you have seen patients.
We all know that if you have to do a redo BMV, the incidence of complications, stay, procedural outcomes, stroke rate, which in our own paper published in Indian Heart Journal shows that the mortality eventuality rate was lesser than the first MVR. So even if I was to get a restenosis at 12 years, I'm okay. In my case series, we did 2/3 of the cases where surgeons had done CMC or OMC. So, sir, I respect both of you surgeons. You are fantastic surgeons. Your patients don't require a second surgery. But I have done surgeries or BMVs for the cases where 2/3 were CMC, OMC out of 70 patients.
No. We don't talk of data and good work.
That is my data. That I'm talking. It's published. It's published on Indian Heart Journal.
Not
it's a
that
data.
publication. What I'm saying is about this particular case. What should we do?
Yeah, so this case,
good long-term result would be there.
Long-term result, 1 BMV I do, my event rate is less than 3%, CMC, OMC rates, MVR rates of complication I've shown you by STS score is almost, including morbidity and mortality, more than 10%. 4 times that of BMV. If you are arguing for long-term outcome, I can go ahead and take this patient for a second BMV based on our own paper, which again says that we can still do a successful procedure without having complication of equal to even the first MVR or OMC or CMC.
So, you know what I want to say? Dr. Kamal started, who's wearing a mask? See, the surgeons are without mask. Our patients are seen by the cardiologist. Echo is done. The physicians see. Cardiologists wear this mask of an echocardiography. and they hide behind that echo machine. They do their echoes. Just say, oh, this area, this is 1.8 if the cardiologist has done it. And if I have done an OMC, oh no, there is more than moderate MR, there is mitral stenosis. It's like that. You're behind hiding. I want to ask, I have seen innumerable mitral BMV reports and the valve area is 1.5, 1.6, 1.4, good result, continue. And you know what happens? After 4 years, 5 years, this patient comes back with severe TR, severe PH, a very bad valve, they cannot be opened anymore and will need MVR. And these patients have a higher mortality. So I think doing a good job primarily, when the patient comes first time, do a complete opening. And Wilkins score, that's useless. I've read entire data in the past 10, 15 days on Wilkins score. It means nothing. It means nothing at all.
Echocardiographic assessment. It's not a clinical assessment. Wilkins score is just to do BMV.
No, even echocardiography, it is not an anatomical assessment. It is nothing about.
So you
BMV.
have even Nagayushi's data, which also talks about another scoring, which is very much on the same line, just for the sake. And I think we had a fantastic debate. We need to end the session. We are running late and we have another surgeon and cardiologist waiting in. And
so
it's always a pleasure to have you both. Nobody's hiding behind masks. We called each other's Superman, Batman, and Superman rather than patients calling us the jokers. So better to be called that.
Thanks a lot. Bye. Bye.
The whole idea was to promote science, and thank you very much to have all of you. Thank you, chairpersons. Thank you, moderators. Thank you all, both the speakers and my co-debaters. We move to next session.
Thank you.